Good afternoon, everyone. On behalf of the Hepatitis B Foundation and our Hepatitis Delta Connect program, I want to thank you for joining today's webinar. My name is Sierra Palecchio, and I'm the program coordinator of the Hepatitis Delta Connect here at the Hepatitis B Foundation. We're very excited to present today's session on hepatitis delta in Romania with our expert speaker, Dr. Florin Caruntu, who is the Associate Professor at the University of Medicine and Pharmacy in Bucharest and the Chief of the Adults 1 Clinic at the National Institute of Infectious Diseases in Bucharest, Romania. We thank him for his expertise and willingness to highlight the burden of hepatitis delta on hepatitis B patients in Romania. And before we get started, I'd like to review a few housekeeping items with you and let you know how you can participate in today's webinar. Please note that all attendees are in listen-only mode and will be muted during the presentation. There is also a phone call-in option, and the numbers are here on the screen. Please note if you are an international attendee outside of the U.S., there may be phone charges for calling in, but for most people, the computer audio is sufficient. If at any time you have a question, please submit it in the chat comment box, and then we will be reviewing those in our Q&A portion at the end of the presentation. And finally, I just want to let you know that today's session is being recorded, and after it concludes, you will receive an email with a link to the recording for future use. And now I'd like to introduce our presenter today, Dr. Florin Caruntu, and I will turn it over to him to begin the presentation. Dr. Caruntu?
Yes, Sierra.
It's all you now. Thank you.
Hello, thank you. Good day to all. I'll try to make a presentation about the situation in Romania regarding the infections with hepatitis D virus, B and D virus, because we have a special situation, a lot of patients and a lot of lack in managing these patients. For the first, you must know that in Romania, the main provider of healthcare is the National Insurance House, and there are very few patients that are that have some particular or insurance, and that's why the National Insurance House has some programs to treat hepatitis B infections, hepatitis C infections, hepatitis B and D infections, and of course other programs from HIV infected people, for tuberculosis, and so on. Next slide, please. We have a lot of barriers that are interconnected in our health system. There are also costs problem, personal problems, diagnosis problem, but all of them are interconnected, and this is a problem for our patients. We can begin with a lack of free investigations specific for the HBV/HDV co-infection. Only the basic tests are reimbursed by the National Insurance House, the hepatics test, the hemoleucogram, and so on. But the specific tests, the HDV RNA, the FibroScan, Fibromax, viral genotype, or quantitative HBS are not reimbursed by the insurance house. It must be paid by the patient itself. There is also a low screening level for the HBV/HDV co-infection because these tests can be performed only in the main hospitals and not all the time. It depends of the lack or not of the tests. The doctors themselves are not with a high level of experience, although the problem of co-infection is known in Romania, but sometimes they do not think that the B patient can be co-infected with D, and so the diagnosis is very late when the problem of the patients cannot be resolved with actual treatments. Also, the protocols I have spoken about are very rarely updated. 5 years, 4 years, 6 years, and so on. So we cannot be with the late. We cannot be with the latest scientific knowledge at current. So all these problems are concluding to a low level of diagnosis of these infected patients. Next slide, please. Of course, due to the very high number of patients infected with B or co-infected with B and D, this infection represents a public health burden in Romanian patients. We have a high number of co-infected patients, a high number of patients with cirrhosis and hepatocellular carcinoma. The co-infection is the first cause of liver transplant, and we have a lack of epidemiological data updated. Next slide, please. Speaking about the prevalence of HDV infection in Romania, we know from some old epidemiological studies that we have about 4.4 HBV infected patients, from which over 23% are co-infected with HDV. This means a large number of 200,000 individuals that are potentially infected, but few of them are diagnosed and fewer are treated. We have also a high number of HCV infected patients, 3.23 upon the latest epidemiological study, but it was performed about 8-10 years ago. The annual incidence of hepatocellular carcinoma, it's high for HBV or HBV/HDV co-infected patients, until 8%. It's 2.5% for HBV hepatic cirrhosis, and until 8% for ACV hepatic cirrhosis patients. So we can say that we have a high level of morbidity and mortality in this segment of populations infected with hepatitis viruses. Next slide, please. Which are the providers of treatment? And of course, the first of diagnosing these patients are the specialist doctors, which make the recommendation and the prescriptions. There are infectious disease doctors and gastroenterologists. In Romania, we do not have the specialty of hepatologist. That's why we are sharing these patients, infectious disease and gastroenterologist doctors. And the family doctors have a limited and only administrative role in this. It was last thing I said is that the family doctors had a very low participation in this process. They are only prescribing the recommendation of the specialist doctor. The follow-up and the monitoring of the patients are done by the specialist doctor. Please, the next slide, please. What are the blood tests performed in Romania? I think that are all the blood tests that we need to diagnose this disease, the HBS and HDV markers, the HBV DNA, the HDV RNA, and of course the non-invasive fibrosis test, the FibroScan, FibroMax, FibroTest, and elastography. Next slide, please. As we know, the hepatitis delta virus is an RNA virus that use for replications the hepatocyte RNA polymerase of HBV virus, and it used also as an envelope the HBS antigen, so it can exist only in the presence of B virus. There are some known genotypes with geographical distribution. In America and Europe, we have genotype 1, and the other genotypes in other continents and countries. Next slide, please. So, what about the Romanian protocol from HDV treatment? We have some treatment inclusion criteria, which consist of biochemical, virological, and fibrosis and necroinflammatory activity evaluation. The biochemical markers are, of course, ALTs and the others hepatic tests. The virological includes the serological markers, the HBV DNA and HDV RNA, and the macroinflammatory and fibrosis evaluation are performed by FibroMax, FibroTest, liver biopsy in the past, FibroScan, and elastography. Next slide, please. We can treat patients from 80 years till 70 years, but all these patients, especially the older patients, must be evaluated for the comorbidities they may have and that are often contraindicating the treatment with interferon. As we know, the interferon treatment has a lot of side effects that cannot be supported by patients with other comorbidities. Also, the patients with very serious disease, with very severe disease, cannot be also treated with interferon because they have pancytopenia, they have ammoniemia, ascites, and other complications of the disease that are not indication from the treatment with interferon. The conclusion at what I said is that the earlier the diagnosis is established, the more chances for cure we may have for these patients, and they can benefit from the treatment with interferon. Next slide, please. We have at our disposal two types of pegylated interferon, alpha 2A and alpha 2B, that are indicated in treating HBV and HDV co-infection. Next slide, please. What are the indication from monitoring these patients? Of course, we must perform their hemograms and liver tests monthly or even weekly if there are severe cytopenia secondary to treatment. And what we have as a particular criteria is the stopping rules that are included in this protocol. These stopping rules are regarding the virologic monitoring. At 6 months of treatment, we must perform an HDV viral load, and this viral load must decrease with 2 logs from the initial viral log. If this is not as we wish, we consider the patient is not responding to the treatment and the treatment must be stopped. Also, at 1 year, every 6 months, we must perform the HDV viral load, and this viral load should decrease with 1 log every 6 months. If these criteria are achieved, the patient may benefit from 96 weeks of treatment. It means 2 years. But there are patients that must stop the treatment after the first 6 months because the viral load doesn't lower with 2 logs. And that means that we have a 6-month treatment without very much benefit. We must stop the treatment, wait a period, and then reintroduce the treatment to these patients. I think that it should be better if we can continue the treatment regardless the evolution of this viral load, because we know that longer treatment gives us higher chances for the patients to respond to the treatment. Next slide, please. What is a national program of HBV immunization? We had and we have also in this moment a great problem in Romania for finding HBV vaccine. It was not available since several years, and that's why the immunization program has changed, and now the newborns are vaccinated with hexavalent vaccine at birth in the first 24 hours, at 2 months, at 4 months, at 11 months. We do not have, for example, a follow-up of this vaccination, nor the revaccination at 5 years, 10 years, 15 years, and so on. As we know, the antibodies are available around 5 years after vaccination. Next slide, please. What are the post-exposure prophylaxis? There are agreed some protocols from therapy from the infants born from HBV infected mothers. They should receive, of course, hepatitis B vaccine and hepatitis B immunoglobulin within 12 hours of birth to prevent, of course, the mother-to-child transmission. But the immunoglobulin therapy is not reimbursed by the National Insurance House. It must be paid by the patient itself. Also, the protocol after exposure to B virus should include the vaccinations with B and also added the immunoglobulin, which are also not reimbursed by the National Insurance House. Next slide, please. So we can say that for the patients there is a large financial burden of treatments. They must pay a lot of investigation for the diagnosis and for the follow-up of this disease, and also they must go to specialized centers, especially in university medical centers. There are about 10 large university medical centers in Romania, and they must go there for diagnosis and treatment. Next slide, please. What are the problems that we are facing every day? Of course, for the doctors and with implication in the treatment, in patients management, it's the lack of experienced specialist doctors. It is a lack of epidemiological data updates. It's a lack of programs of medical training and the lack of possibility of investigation and treatment outside the university medical centers. These facts are limiting the access of patients, of course, to diagnosis and treatment. Next slide, please. How can we prevent the future transmission? Of course, there are national vaccination program from newborns and for adults at increased risk for hepatitis B. And in this category, we can include patients that have sex or live with someone who has hepatitis B. We must test all the family. If we have a member of the family, his parents, his brothers or sisters, his children, all must be tested for hepatitis B, because we have surprises to find new patients in this environment. The patients with CDD, the patients who have sex with more than one partner, the men that have sex with men, the drug users with needles, the patients that come in contact with blood or blood products at work, the patients that are getting hemodialysis, patients also that are traveling in countries where hepatitis B is very common, or the patients with diabetes. Next slide, please. What can we do to improve the diagnosis of these patients and also their treatment? We can improve with the basic line of the family medicine. The doctors can test, make the routine screening for all patients, not only for B hepatitis, also for C hepatitis, because as I said, we have a lot of patients also with C hepatitis. They can monitor the antibodies for those who received the vaccine. The blood test for hepatitis must be performed for any patient that is admitted in a hospital. Of course, all the patients known with B infections should be tested also for D infections, D co-infections, and of course, treating the HBV infection. Next slide, please. How can testing rates be improved? Of course, that national programs are the most efficient tools to discover and to diagnose these patients. They must be made periodically, made an evaluation of viral hepatitis markers of insured or uninsured persons. Also, the medical education program for medical staff, especially for those who work in maternities, family medicine, oncology, rheumatology, and dental practice centers, and medical education programs in school should be performed. All these methods should raise the level of awareness also for patients and for doctors, and for sure they would be more attentive and discover and diagnose and treat more and more patients affected by this disease. Next slide, please. What we have in this moment in Romania, fortunately, the treatment with pegylated interferon is reimbursed by National Insurance House according to Romanian protocol. As I said, we have some criteria for including patients and also for stopping the treatment for certain patients, but they can benefit for treatment for 2 years of treatment reimbursed by the insurance house. Of course, we have difficulties in accessing the clinical trials of HBV, HDV co-infections. We know that there are not many trials worldwide for this disease because there are not many new drugs in study for this disease, but this is an unmet need for these patients, which do not have a therapeutical solution at their disposition, and accessing some clinical trials should provide some treatment for some of our patients, should raise our experience, and should be a hope for the future. We participated some years ago in he did 2 trials. That was a 96 weeks trial of combined therapy with pegylated alpha interferon plus tenofovir. But this was the last trial that we accessed. Next slide, please. Which are the new steps and the hopeful developments in treatment? Of course, the first one should be the access to new treatments, to access to clinical trials and national or international grants. But we must not forget that what we can do in this moment is to diagnose the patients and treating them as soon as possible, because, as I said, if we treat them early, we have greater chances to cure them. Also, we must have a proper management of cirrhosis and hepatocellular carcinoma. And also in the hepatocellular carcinoma, we have few doctors that are preoccupied and which are treating this kind of patients, with few centers in all the country. they are overcrowded and cannot afford to treat all the patients and have a good clinical care from them. Regarding the access to liver transplant with advanced liver disease or hepatocellular carcinoma, we also have a problem because there are large waiting lists in Romania, and as far as I know, we have a single center in Bucharest in Romania that performed liver transplant. Next slide, please. Thank you for your attention. Thank you, Sierra, and I'm waiting.
Thank you, Dr. Caruntu. So now we'll begin our question and answer portion of the webinar. So please submit your questions for Dr. Caruntu in the comment box. So we'll let those trickle in, and we will start with our first question. So what are some of the downsides of using interferon for patients?
Sorry, what are the?
What are some of the negatives to using interferon for patients? Why might it not be good or ideal? As the only treatment option.
Why we are not satisfied with interferon treatment, you mean? Yes.
Yes.
Because there are many problems with interferon treatment. For first, there are patients that are supporting very hard the treatment. Also, young patients that must reduce the dose of drug because cytopenias. They must make the injections for a year. It's a long treatment with a lot of side effects. And this is about the drug. About the disease, we can say that not all the patients are responding to this treatment. That are some patients that seem to go well, that have the liver test normalized and so on. The viral load is lowering and so on. But after one time, they make a relapse and they must be treated once more. It's a long treatment. It's a hard to endure treatment, and the results are not as expected.
Thank you, Dr. Caruntu. I think that answers the question.
And also for the older patients, as I said, with comorbidities, it's contraindicated. You cannot treat such a patient with interferon. It's very risky for the patient.
Yes. So we have another question. How successful might a liver transplant be? And does the hepatitis B or hepatitis D come back after the transplant?
It's a good question. We have a lot of patients that have performed transplant, and usually, if they are taking drugs, oral drugs, after liver transplant and immunoglobulin periodically, they do not get reinfected from B and D virus. So we have patients that are surviving after 10 or 50 years after the liver transplant, and the patient was initially with decompensated cirrhosis or hepatocellular carcinoma. So the evolution after liver transplant is the transplant is successful. It's hopeful. It's good.
Great, thank you. So another question, are all pregnant women tested for hepatitis B during pregnancy in Romania?
We find often women infected with hepatitis B because now they perform the markers for hepatitis during the pregnancy or before the pregnancy, but mainly during the pregnancy. We diagnose often the women already pregnant, and they come to us to ask what should I do if with this condition. Uh, we have good therapeutical resources for these women. If they have a low viremia, it's enough to vaccinate the child and to give him immunoglobulins, specific B immunoglobulins. If the mother has a very high viremia, we can use also a treatment with tenofovir in the last semester of pregnancy, and this should lower very much the risk of vertical transmission. It's more difficult with women that do not perform the markers for B or C infection before pregnancy or during pregnancy. So we have also children infected from mother.
Yes, thank you. So you mentioned the immunoglobulin not being reimbursed by the national insurance system.
Yes.
Do you have any estimates on what the cost might be for a patient who needed it for the baby?
Yes, it's not very. It's about, I think, 300 euros, about 300 or more dollars to say so. It's not very low price, it's not very affordable. But for the health of the children, mother are buying them from pharmacy.
That's very expensive.
Yes, as I said, it's about 300 euros.
Yes. So we have another question. Do you know, or are there any studies on the way that most people get hepatitis delta in Romania?
No, no, I don't think that we have any study for hepatitis delta in Romania at this time.
Okay. And
I know I had some patients that wanted to go in Turkey, for example, to be included there in the study. They were looking for some study site to benefit from some new treatments and so on, but they didn't found, and we do not know any study in Romania for hepatitis delta.
mhm. So we have one more question. Does 2 years of interferon increase the likelihood of someone clearing hepatitis delta?
Yes, in this moment we have a very good experience with longer treatments, and for sure longer treatments are with better response, even if the patients that became undetectable, for example, for D virus, they must continue at least 6 months or more the treatment with interferon in order to consolidate the response. Otherwise, it's a very great risk of relapse and reapparition of regrown of the virus. So we had a good experience with patients that performed several treatments, 2 or 3 or 4 treatments, because they didn't responded or partially responded or relapses after the first treatment. But if we insist with the treatment and we go further with a longer period and so on, we can obtain the clearance, the viral clearance. So it should be a proposal. As we give it for the hepatitis B, we cannot make viral clearance from the liver. We give treatments for 5, 6, 10 years and so on. I think that also a longer interferon treatment should bring us and for patients, of course, great benefits.
Thank you, Dr. Caruntu, for your thorough answer. It looks like those. Oh, go on.
Thank you, Sierra, I said.
Oh, thank you. So those are all the questions we have for today. If anyone else has any questions going forward, please feel free to email us and also visit our website for more information about the program. And we'd also like to invite you to fill out the survey and give us feedback, as well as let us know if you'd like to receive future information from us. And you will also be emailed a recording of the presentation after it concludes. I'd like to just turn it over to Dr. Caruntu for a few key ending points before we sign off today.
Yes.
Dr. Caruntu, do you have any ending points you'd like to share with the audience about hepatitis delta in Romania?
Of course. The first and most important thing is to know the risk factors from getting this infection and to avoid them if it's possible. The second point is that some patients that know that he has a risk factor and so on to be tested for hepatitis viruses, because as I repeated several times, the early diagnosis is very important for the success of the therapy. The patient is feeling good, he has not complaints, anything, he do not go at the doctor to be tested, but there are many patients that are diagnosed by chance for other disease. When they are admitted in hospital, we perform liver tests and liver and hepatitis markers, and we diagnose them very quick, very early. It's a very important thing. And if you know as a patient that you have a viral infection, you must go to make a complete evaluation of your disease, even if you do not have any complaints for it, because this is a silent disease. It evolves without many signs or symptoms, but when the symptoms or signs appear, already the disease is very serious. So we must diagnose it and treat it as soon as possible once diagnosed. And of course, change your lifestyle if it's necessary. I'm speaking about obesity, of diabetes, of alcohol use, of drug use, and so on. And also, you must know that if you are infected with some hepatitis virus, you must protect also your family, and they must be also tested and vaccinated in order to be protected for this virus, not to give them also your infection. And of course, speaking specifically for Delta hepatitis, there are great expectations about the treatments, the new treatments, because as we know from a long time, is the most severe and the most rapid progressive liver disease from the viral ones. Most severe and more rapid evolves than C hepatitis or B hepatitis, and we have lots of very young patients which already have cirrhosis or they develop hepatocellular carcinoma. So it represents a very serious burden of disease, especially in countries where this disease is not rare, has a high prevalence, as is in Romania, in our country. Thank you.
Thank you so much, Dr. Caruntu, for your expertise and for bringing attention to this issue. And thank you to the audience for attending today, and we hope you have a great rest of the day. Thank you again, Dr.
Thank you all for listening us, and thank you, Sierra, for this opportunity.
Thank you.
Keep in touch. Thank you. Bye.
Bye. Bye, everyone. Thank you.